So, welcome back to Wandering into Wellness.
Hey guys. So today we're here with Jane Uygur. Jane is a GP. She's just currently completing her PhD in compassionate medicine, and we sort of bumped into each other in my shop, the Hopsack in Rathmines there a few weeks ago. And I don't even know how we started chatting about it, but as soon as I heard what you were doing, the hairs were up in the back of my neck, because it's such a fascinating area, and it's something that we're really aware that there's this great dividing line between the medical profession and the general public, and that gap as it increases is so deleterious for health and for our healthcare system. And I was just amazed to hear that somebody was engaged in this, and it's not just you, but you're like, there's a community of people who are all interested and engaged in this. So maybe can you tell us a little bit about where this idea of this PhD has come from, and what fueled you drove you towards that, maybe?
Yeah, sure. Well, I guess I'm Canadian originally, and I was working in Canada. And at that time, I had two very young girls. I was doing some coursework in a master's. I was practicing as a GP and doing a lot of work with care of the elderly. And I was pretty tired. I was exhausted, and I was trying to look at ways to kind of keep my resilience up and take care of myself while I was taking care of everybody else. My brother gave me a fantastic book one Christmas called Medicine and Compassion, and it was a conversation basically between a Buddhist monk and a physician who had been working in Nepal. I realized, actually there is a common theme in everything I'm doing in my life, and it is about compassion, and that's what I need to really kind of nurture in myself in order to keep all these things going well,
Yeah. It's like an inside-outside kind of practice, isn't it? Yeah.
Exactly.
Yeah.
And so that kind of got me interested, and as I was doing this master's, and I had to come up with a thesis topic, I thought, I really am interested in this. I feel like I could read for days, weeks, months on this, and that is a good kind of PhD topic to choose, because you're going to be doing a lot of that. So that's kind of how it started. And from there, we moved to Ireland shortly after that, and I was not practicing as a GP here, just because of the difficulty with getting my qualifications recognized.
Transferred,
So I had lots of time to think about my PhD, or at that time my master's work. And so I ticked along being a mom and doing this, and completed my master's work and came up with some great stuff. Then went back into working mostly in medical education, and thought, you know what, I love the stuff that I came up with, but I feel like I haven't really done enough to help people kind of apply it, to be able to make the impact that it's worth. And so that's when I decided to go back and do the PhD. And so here I am, and I'm really I still have a long ways to go on the PhD, but
So what you've seen, what you've seen in terms of like where we're at in terms of compassionate medicine now, the pressure within the health service to see multiple people, to deal with volumes, how here's a tiny question for you. How do you reconcile that with the need for compassion and the need for that bedside manner?
Yeah, I mean, I think this is one of the difficulties, is that there's so much pressure on GPs and other physicians to, see people quickly, and they're dealing with, they're getting frustrated because even if they want to get things, done for their patients, they're frustrated because they can't actually get the services that they want. So there's, time pressures, and there's an inability to act on the stuff that they feel
on
that
their
their
own instinct
patients.
and what they feel is right.
So there are a lot of systems things, but I think that what that says is like, wow, we need even more resilience as physicians now to be able to be able to provide really compassionate care in this sort of difficult situation. So yes, there are things that we need to do on the outside, but I guess a lot of what I'm looking at is what can we do on the inside within ourselves and within our small little community of our little practice, when we're, when people are walking in the door to our practice like, are they getting this feeling of compassion right away, or are they feeling pressure, time, stress,
Yeah.
So a lot of my PhD focuses on what actually happens when you walk in the door.
Okay.
And is it, it's not just the physician and patient, but it's also the receptionist.
Environmental factors.
It's the space that you're in.
Yeah.
And how can all of that, what's the best way that we could do all of that?
Okay.
Given that we are living and working in kind of a stressful situation.
Yeah, there's constraints. There's always going to be constraints.
Yeah.
So, like, have you found in Ireland? I mean, obviously you're from Canada, but you've been here for, did you say 11 years, 12 years?
12 years.
Yeah. So, like, most of your work. Wow, that's a very low plane. Sorry. What? For real? Is he landing in the park? Wow. Anyway, sorry, excuse me. But yeah, so have you seen like a significant difference between the relative appetite for that type of compassion care and that thought process in Canada versus in Ireland? Have you, like, culturally, are we on the same page, would you say?
I think Ireland, because it's a smaller place, tends to kind of maybe be a little bit slower maybe in coming on board. Like I kind of feel that the system here is a little more traditional.
Okay.
But at the same time, I think Irish people are very open. Actually, like you see things, how much Ireland has changed in the 12 years that I've been here. They are, Irish people are just incredible that way.
It's interesting, isn't it?
So I don't think that's a stumbling block in a lot of ways.
But are there things we could maybe be looking at applying from Canadian medical system? Or are there specific things that you're kind of like, you see, this would be like a good first step sort of thing from a systems point of view?
Yes.
Or?
Well, I guess kind of the big thing is in Canada we have universal health care.
Yeah.
So that would be a big thing.
Yeah.
And I know there are a huge number of GPs here that would like to see that happen. But it is a challenge financially, to get that kind of thing going. I mean, universal health care is a huge financial burden on the country.
Yeah.
It's amazing how, because part of my childhood I grew up in England, and
all over the place. I grew up in everywhere, but anyway.
And yeah, you just take it for granted. My friends that are still in England, or even my parents, when I'm talking about going to the GP, or this thing needs to happen, or I need to go to the dentist, or all these different things, and I'm like, yeah, but that's going to cost this, or that's going to cost this, and they're always like, what do you mean that's going to cost that amount of money? And it's so ingrained in England that you just go to the GP when you're sick, and then of course you're going to go, whereas here you're kind of, when you have a young family and you've got pressures and financial pressures, you're thinking, do I really need to go that 60 quid? It's a lot in a family budget. And that's a problem, because it's a deterrent. I mean, now we have the free under 6 care, which is huge, because when you've got a little person, you're kind of going, ooh, I don't want to be the person who's always there. And in fairness, I'm not that person. But there are people who are kind of worried and anxious about it, but they wouldn't go because they don't want to just keep dropping 60 euros. And now that you can go, actually, I'm just not sure about this, I'll just make sure. That's a huge thing, but we need that to carry on into the rest of the population, and not just for the under 6s.
Yeah. And I mean, there are challenges to it. I remember working in Canada where there were people that were not using the services appropriately, and so it meant that there were backlogs and
abuses or whatever.
And it's just because they've always had it, and instead of a privilege, it feels like a right, and so there is the downside of it.
Sure.
But I think from a point of view of the respect and dignity of each individual, if you're basing your healthcare system on that, then universal healthcare is the right way to go.
Biggie. Yeah. Okay. So where you are at now, do you think that, like, when you're about to enter back into GP practice, is that what you're saying?
Yeah.
So that's going to be a very exciting GP practice. I mean, you're not going to be able to not apply all the things that you've learned. Have you got a strong kind of defined image in your head of how it's going to look, of how things are going to work?
Yeah, but like the space. I'm
about the space.
Yeah, me too.
Space.
Yeah, particularly actually. Yeah.
Well, actually, I have been spending quite a bit of time thinking about the space, and it's interesting. I just was watching a TED Talk last week, and I can't remember the name of the woman, but I'll let
We'll
you
get
guys
it.
know what it
We'll
is
put it on the
afterwards.
links.
But she's in design, and she was talking about how her work is on how do we create a feeling of joy in a space. And she's broken it down into a number of things. You know, it's color, it's a splattering of lots of little things, it's around objects, you know. So I think that there is you know, knowledge out there about
Like a
how you
method.
can create a space that feels like that. So, you know, I guess what I'm starting to look into now is what is it that patients would feel makes a space feel compassionate.
Yeah.
So that's part of the exploration that I'm on right now. Is it, you know, is it color? Is it smell? Is it, you know?
And I imagine it's going to be quite diverse, because like if you look at even like incense, some people are just, they want none of it, and some people want all of it, and most people aren't in between. They're usually either side of the fence. So it's difficult to find a really inclusive model for that, is it?
I think
exactly.
a huge thing is also like, when you're thinking about going to see a doctor or you're going to the hospital, the thing that scares most people is that feeling of the medicalized area that you're in, and that fear of, okay, then that means like machines, and it's like a lot of antiseptic, you know, and spaces that are necessarily kind of linear because it's easier to clean or to keep clean, but it feels inhospitable. When we think about our homes, they're soft, and they have cushions, and they have soft edges, and they have nice diffused lighting, and like for some people it has nice smells or it has nice music or whatever. So it's trying to bridge that gap between keeping it functional, I imagine, and also keeping it a space that doesn't feel clinical.
Exactly. So it feels, you know, I think for us it's going to be important to have, I think people do want to feel that when they go into a GP surgery that it's clean,
Really,
because cleanliness, you know, is
Next to godliness.
is next to godliness. So
important.
that's important. So you do need to have a little bit of, you know, that
We
white
have to the
clean
Angelus in a
surface.
second. Is that okay? Sorry, I didn't. Anyway, all right, moving on. I may edit that.
But at the same time, you don't want it to be all white and gray.
Yes.
You know, in this lovely TED Talk, she was saying, you know, if these are the things that give us joy, and she had loads of pictures of color and round things and clusters of things and natural things, and then she shows us this is where we live, in these skyscrapers with, you know, lots of paved roads and not a lot of green. So, but as you say, you know, a lot of this might be individual, and you see that even in, you know, trying to provide compassionate care to an individual. It's very different for different people.
Go explore it. No, finish exploring the space thing first, because that's next on my list.
So it's kind of trying to, I think, find what most people would find is comfortable. And so, like, we were having discussions, myself and my colleagues, about music. You know, music or no music, what kind of music, you know. And even among the three of us, we go, oh God, I wouldn't want to listen to that. You know. So we found it very hard to kind of think about that. So this is part of the research that I'm doing now. Is you know, is there research on, you know, what type of music is most appealing or calming to most people. Now, maybe you might not get everybody, but trying to,
a bit, though,
but also, like, not everyone's going to come to your practice, right? You're going to get your tribe of people that fit with you. So there's no way that you can be all things to all people. You have to go, this is me, this is the practice that I'm setting up, and this is for the people who are calling for this. And then there are always going to be people on either end who aren't calling for that, who actually are happy with the way that it is, or who are never going to be happy with whatever way it is.
And, you know, and everybody's priorities are a little different. So, for example, in the practice I had in Canada, I recruited another woman to, we were sort of both working part-time, and there were a few other GPs in the practice. But I was trying to do some more care of the elderly work, so she was coming to sort of fill in some of the gaps, so that because I couldn't be in the clinic as often. And we had completely opposite styles in a lot of ways. I mean, she was very compassionate, but in a very different way. Extremely time efficient, get to the nub of the answer right away. So it was very interesting to see how the patients gravitated one way or the other. So if they were people that, you know, time was really important and they didn't like sitting in the waiting room.
They're like, phew, thank God Jane is gone, this is brilliant.
Exactly. They went to Margaret. Exactly.
I'm guessing this.
But yeah, so I would struggle with trying to keep on time, because if somebody says to me at the end of the consultation, and by the way, I'm just really upset because my daughter XYZ, I think, it's important to spend that 5 minutes talking about that, because this might actually be the really root cause. So I always feel that it's time well invested. And when I come in to my next patient and I say, I apologize, I'm a little bit late, but sometimes things come up, and if ever something comes up like that for you, I'll be there for you. And that's kind of how I try to excuse myself.
Okay, good.
But, time can be a very, very critical thing for a lot of people, and some people just, they find it hard to, to forgive that.
Yes, so, when it comes to compassion for different people, so in Ireland, well, there's there's stereotypes all over the place, obviously, but in Ireland we have like a very strong cultural stereotype of a man who's kind of like, doesn't really share the emotions when he's upset from maybe having a pint with the lads.
Yeah.
And even then it's kind of like done in a joking way, and he probably doesn't want anyone to pry into his kind of background any more than he's really willing to give, and very guarded. And then there's some people who just really want to be enabled to speak up more.
Yeah.
How can you train for that? I mean, like, that's vocational, isn't it? That's like whether people are in the right or the wrong job.
Yeah.
Kind of.
It's very difficult. I mean, there are all kinds of things you can do to actually train yourself to be more compassionate, and I could talk about that for yonks. But in the end of the day, different people, when they come in front of you, there isn't a formula. So, for example, when we're teaching medical students, we've tried in the medical profession to try and give young doctors guidance on how to deal with these things. But there's always this, you have to have some wisdom of experience to know how to apply them, even when you have really good, well set out rules. So, for example, if often as a physician you're going to have to break some bad news to somebody, so we have an approach of how to break bad news. And so you ask them, is there anybody with you today? Would you like them in the room so that they're going to have support? And there's the whole delivery. But sometimes they don't realize, the students, that they are applying this in the wrong situation, or that they're not tweaking it just this way or that way for this particular individual.
Yeah.
And so,
you play the field as you see it, sort of thing. It's
exactly.
Use the instinct.
And it's really kind of getting into that other person's shoes, and so I think so far in medical education we have relied more on this kind of, this is how you do it. So, for example, in the patient-centered clinical method, we use FIFE: feelings, ideas, function, expectations. So, how do you feel about the situation? What are your ideas about your illness? How is it affecting your function in daily life, and what are your expectations of this visit? Okay. And they are all very good things to ask. But it's at what point in the conversation do you ask the question? So do you at the end of the interview go, what are your feelings about this? What are your ideas about this? How is your function? Do you sound like a robot? You know what I mean? And so, it's important to get those things, but it's how you do it. And this is how, the next level that we need to get to in teaching our young physicians.
And it needs a lot of practice, eh? I mean, it needs a lot of life experience and just practice, and doing lots of those
But it's also about
types of
how do you relate to yourself, isn't it? It's a lot about learning, are you actually able to show compassion for yourself in your daily life? And then can you translate that? Because we learn that ability to be compassionate for others by experiencing us being compassionate to ourselves, and then practicing compassionate to those people around us. And if you're then put into that work situation where there is a time constraint and you're meeting this person and the next minute there's someone else's completely different situation than another one, and you're having to quickly shift into those gears, it's hard to be mindful of bringing up that experience and doling it out in a way that's appropriate, but also still being compassionate to yourself at the same time. It's a lot to manage.
It's a lot to manage.
It's a super challenge.
Isn't it? Super challenging.
I mean, even my tiny little world of short health consultations on the shop floor, but it can be 20 of them, 30 of them in a day, and sometimes it's kind of coffee machine's broken, I've got a cold.
Yeah.
You know, 5 orders to do, my husband got high cholesterol. But like, you know, and it's like shifting gears like that is incredibly difficult. Imagine for any human being, and imagine GP practice, it's the same, if not tougher. I mean, like the health conditions you're dealing with are significant, like every single one of them.
Yeah, and you know, I was teaching a course called Early Patient Contact with first-year medical students, where I was getting patients to come in and talk about the experience of illness, so that you know, students could see not just, you know, this is what happens in the heart, but like this is what it's like to live with heart disease or and whatnot, to kind of help them build that wisdom in a kind of vicarious way, you know. But you can see, I don't know where I was going. Lost track of my
Compassion to themselves, maybe.
Yes.
And like maintaining that center.
And you know, this is something that we're not really particularly getting at the nub of, because it is, you know, generally physicians, this is a big generalization, but often physicians are insecure overachievers.
Okay.
You know,
Yeah. Well, they've necessarily had to be for the first part of their life anyway.
To get through it.
Absolutely.
Yeah. And so, you know, and a lot of the things that they learn in medical school are about dealing with pressure and dealing with stress, but we don't necessarily do a great job of giving them the tools. It's just kind of like the Leaving Cert. People will say, you know, well, the Leaving Cert teaches kids how to deal with stress. Well, no, actually, it puts them through stress.
Yeah.
And, you know, they figure out some way to deal with it. We're not actually teaching them how to cope with stress. And so this is something we need to be a little bit better at, because there is a lot to process as a physician. And I say to them in this course, this is where I was going with it, is, you know, generally when people come in to see you as a physician, they're not having their best day.
Yeah.
And so you have to, you're taking on a lot of this stuff, and you have to be able to process it and let it, you know, work through it, and then put it to one side and be able to go home and not have it, you know, not have a number of monkeys on your back.
And I imagine a lot of those things do bleed into people's personal lives, and we know that in every work, our line of work, but particularly when it comes to dealing with human health, and you're going to, you're picking up a lot of people's other, you know, not negativity, but they're necessary kind of like insults to their physiology, and what that's knocked on into the rest of their life. It's, I mean, we have a thing in the shop we constantly try and remind ourselves, you know, when somebody comes across as impatient, or there's kind of a negative interaction that seems to be started by a customer, like, well, often you're dealing with somebody who's got like they're here because they need help with their health, like by and large, you know, and just put yourself in that moment where you lost your keys, your son is sick at home, you've been called for whatever, and then you're required to deal with a human being in front of you from first principles, and then you're not going to be your best self. You're just not.
Yeah. And it's hard to keep those boundaries, because I mean, it's the same. All our professions have crossovers, but I'm sure it's the same in other ways. Like in yoga classes, you get people coming in, they want to chat to you at the end. Sometimes you can't because you're rushing to another class. Sometimes you can, or maybe people coming in late, or wanting to leave early, or they're not happy with it. Oftentimes, for example, if you're teaching a regular yoga class, you get a lady coming in who says at the beginning, "Oh, by the way, I'm 7 weeks pregnant. It's okay if I stay for the class." And everyone feels differently about that. But as a pregnancy teacher, I wouldn't feel comfortable with them being in my regular class, and insurance-wise, you can't get insurance for under 14 weeks anyway, so that's another reason. And so I would say, no, sorry, you know, I know you really want to come, and thank you for coming, but you can come to one of my pregnancy classes from 12 weeks or 14 weeks, dependent on the studio. And people get very disgruntled by that, and often they would say, but I've been to my GP and my GP says yoga's fine. And then you have this conversation where you say, but has your GP been to my yoga class? Do they know what this yoga class, they mean generically yoga is good for pregnancy? That's true. But what's going to happen in this class where I'm teaching a core class right now, it's not appropriate for you at this stage. Right, I'm gonna go out to my GP and write you a letter and say that I'm okay to come to this class. And you have this interaction where you're trying to, you see it from their shoes. They love yoga. They are having a tough time. Early pregnancies are really hard. It can be really hard, and they just want to have this time for themselves that they've carved out. And you're telling them, no, I can't give you that time. And it's hard to interact with them in a way that's sympathetic, and then go and teach your class in a compassionate way. So that's like my tiny experience of that world. It's really hard. It takes a long time to learn to be able to put the boundaries in place so you can finish that interaction and within seconds go on and give everyone else what they need. And that's essentially what GPs are having to do every second of the day, in between every interaction.
And you bring up the whole issue of boundaries, which is really important. And I think this is one of the things, like the study I did for my master's, I did long interviews with individual GPs around the themes of compassion, and just asked them, what is it to you? How does it work? Does it help you with your work? Does it hinder you in your work? What makes it, what makes you more compassionate? What decreases your compassion? And tell me about, where compassion was important in interaction with the patient, etc. So these are kind of some of the themes that we were exploring. And one of the things that came out was boundaries, and that compassion actually requires you to have boundaries. And I think some people think that compassion is limitless, and that now the thing is that we do have this potential for limitless compassion, but whether that's good for the patient or the person in front of you, so to just say yes, it's okay, do whatever you want, is that really truly compassionate? So when I was doing
tough love.
Exactly. Sometimes compassion is tough love. And Aristotle had wrote about the virtues, and one of the virtues he described was compassion. And all the virtues really are a median between two extremes. So compassion is, for example, it's a median between indulgence and indifference.
Hey, cool. Okay, great.
So when you think about that, compassion takes on a very different kind of flavor, doesn't it?
Absolutely. Well, you realize the end point for it a little bit more, don't you?
Yeah. And I think that I think physicians and sort of the medical world has been a little bit hesitant about that word compassion, and it's written everywhere. Like Hippocrates wrote about it. Everybody's writing about how important it is. But then the actual practice of it is so challenging, and we haven't kind of explored it enough that we can really say truly what it is in medicine, and we don't know how to enact it really well within. And I think some physicians kind of recoil a little bit from it because they're like, I can't give any more. I can't give any more. I'm already up to my eyes. How can I be compassionate on top of that? And I think if we spent a little bit more time exploring what it was and realized actually it is this really important balance between indulgence and indifference. Because what happens for a physician, one of the doctors I interviewed described this very well. He said, you go in as a medical student and you have to, deal with anatomy, and you have your first cadaver, and you have to kind of deal with the fact that there's a dead person there, and this wasn't a live person, and mortality and all of that, and you deal with that, and then something changes a little bit, and then, you go on and you experience your first, something pretty big happens, your first patient dies, first time you see something tragic happening, and again, there's a shift, and there is a tendency to just put up a wall in order to deal with this. And the more pressure there is, the more this is it's a normal self-protective mechanism. So to actually, and then there becomes this mythology of, to be good, you have to be tough. You have to be tough to get.
I feel like that's a country and western song.
Exactly. I'm sure it's a theme through most of them. And so it's really kind of being able to say, well, you know what, you're doing yourself a disservice, you're doing your patients a disservice by putting up that wall. What you need to do is do the work that's required to be able to kind of access your wisdom and access the patient's wisdom. I think that's the other thing. There is also a power dynamic that happens in the patient-doctor relationship. Patient is coming in with feeling not on their best day. They feel vulnerable. They don't know what to do. They're coming to you for help. So instantaneously, there's a power differential. And as a physician, you can use that power wisely to guide people, maybe to make decisions that they are finding difficult to make, because or the evidence says, as in Western, that this would most likely help them feel better. But you have to bring them along in a way that it's comfortable for them. So, for example, smoking cessation, like quitting smoking is hard. And so having the conversation in the right way, at the right time, that takes a lot of wisdom in order to help people kind of make those.
Rather than just be the same voice as every other voice.
Yeah. Here, read the pamphlet. There's this, there's that, it's really quite challenging.
And we don't respond well naturally to going into a situation where we're feeling vulnerable and we feel like there's us and there's them, and then being told information and not feeling like we're being listened to or being valued.
Exactly.
And when you have a great GP that manages to make you feel like you're coming in on a level and you're asking for help, but they don't feel like they're above you, that's a huge part of it, isn't it? That's like the first step into feeling like you're being heard.
Sort of like good parenting in a way, isn't it? Kind of like identifying and coming to that level, but still having not a distance, but such an awareness that you are the person standing there with something that they can get something from, and you have to kind of like allow them to opt in, or like give them that kind of like,
and being aware and being aware in that same moment that you can be open to the learning as well, that it has to be this two-way thing. And so long, I think when people feel like the other person listening is hearing them correctly, and also is open to the fact that they can learn from that. That feels really different. Like I have a great GP in Greystones called Dr. Nick Breen. He's like you can never get his appointments, but he's great. And he's primarily my son's GP, but I also go to him. And what is so great is the way that I always parent my son is that we just talk to him on a level, and we just tell him the truth, and there's none of this kind of, oh, you're going to go into the doctor, here's a birdie, jab you with an injection, and then just like distract you. So when I first went to Nick, I was like, please just, if you're going to look in his mouth, tell him that you're going to look in his mouth, tell him what you're doing at that moment, and just be honest, and tell him why you're doing it, give him reasons, and then he'll be really compliant with you. But if you start trying to distract him, that's not going to go great for you. And Nick was really good about just listening and going, okay, I hear what you've said, and I see where you're doing it, and maybe I can learn from an interaction with this kid and his interactions with me. Maybe I can learn something about how he is. And my son just loves it. He doesn't. He just goes in. There's no fear. Okay, you're going to do this, some weird thing that's going to happen, and he's just completely compliant to it. And at the same time, he brings a sense of fun. So he's doing the fun stuff, like making the what's the face? Speculum?
The spatula
thingy.
He
like draws a little face on it and stuff. But he's not going like, over here, jab it in. He's making it funny, making the experience fun, so he relaxes, and then he's relaxed his mouth, and then he can open it, but he's got a function out of it. It's not distraction, it's respectful. And the linchpin of that relationship, isn't it, is respect that needs to go both ways.
Absolutely. And that was one of the things that came out in that study that I did, was that respect is huge. So it's being non-judgmental. And it's challenging because, as a physician, you're kind of taught to make judgments in order to be able to, so it's being, sort of judging the medical problem, but not judging the patient, and showing total and ultimate respect, which is tough when you've gone through medical school. You think you're pretty
kind of a hotshot.
Hotshot, and no, actually, the best physicians are the ones that are not. Putting themselves above the patient. So it's respect. It's also, it's really saying, look, this is happening in the space of suffering generally, and this is what suffering is. That's another thing. Like, suffering is different than sort of having an illness or being sick. Suffering is it's all about kind of, what we believe is happening to us.
This is the psychosomatic aspect of it,
our fears of mortality, all these kind of things. So so we don't really talk about suffering in medicine. We talk about what the illness is, what the diagnosis is, what the symptoms are. So I think we could do more as far as that. And really understanding too that this is about a relationship between two people, that, and your relationship is part of the process of healing. And that's a different kind of.
That's the thing I wanted to ask you next. So where are there studies? I know there are, but can you talk a little bit about studies that show that where compassionate intervention or interventions that look at the whole person in terms of mental well-being, etc., have augmented the medical outcomes? Are there lots of them? Are there very
There,
few?
there are, like there is, there's one of the first studies that was done on, with a compassion intervention was done in the States in an A&E department, and it involved people who were frequent visitors to the emergency room, and often, had problems with homelessness and whatnot. And they had kind of compassion interventions, which involved really kind of having them connect with, I think it was mostly a social worker, to really look into what the situations were and have some follow-up relationship with that person. And indeed, they found that these people ended up coming to the emergency room less.
Right.
So and there's another study just with the common cold and physicians showing empathy. Like, did they show empathy in the consultation just for the common cold? And the time of the common cold was reduced. In patients who saw a physician who was empathetic. So there is, and there are kind of studies that maybe they don't call it compassion, maybe they call it empathy, maybe they call it other things, but you can see that a compassionate approach has been taken, or a patient-centered approach is kind of another catchphrase, and you do see that there are results.
Yeah, and so can you talk about the overlap between compassion and the placebo effect a little bit? Is there, because that's, because it's something that doctors are taught to kind of put aside. It's like it's a thing that's kind of it's given less weight in study results. It's taught to kind of be very frustrating when it comes to studies, and but it obviously necessarily, compassion is that ability for people to feel better because somebody's maybe listening to them or whatever, engaging. Like, where does that crossover begin and end?
Well, I think there is. I think there is something, because I think the placebo effect is about I've gone to see somebody, I've had a conversation about what's going on, they've given me something, and all of that process of unloading your burden, having a discussion, feeling that you've got hope, that this may be something. All of those things are important in the healing process. And so I think there is definitely an overlap between the placebo effect and compassion, because a lot of what compassion is, involves those different things.
I think we know a lot that stress response lowers the immune system, right? And that stress response is kind of a big bracket, isn't it? It can be like sadness, it can be like anger, it can be frustration. So it seems natural to conclude that if you felt like you were being heard, that you were being cared for, that someone was making you feel better about the situation, more hopeful about the situation, that would naturally be the antithesis of the stress response lowering the immune system. And so then, therefore, the immune system might kick into gear, might work a little bit better, and time lengths might be shorter.
Yeah, absolutely. And I think, like, a lot of, when I was interviewing the GPs, they recognized this, that they recognize that, that all of these things do have and this is why, one of the reasons why they feel compassion is effective. So they talk about, the kind of things that people need, like hope, and that providing hope is a form of compassion. But then they also talk about the things that, impede them. So, one of the big things they were talking about was Pandora's box.
You start with one thing and just...
you start with one thing, and you realize that there is something else going on there that needs to get to that deeper level. And it's usually the phrase psychosocial issue. It's something maybe not on the physical side, but it's the emotional or the social side of what's going on that's contributing to the whole picture. And a lot of physicians don't feel confident in dealing with those issues. They don't feel maybe as skilled, especially when they're younger and just fresh out. I think over time, a lot of them do feel that they have more skills in that time. But there's also this fear of, if I go there, all the stuff is going to come out. I'm going to have to feel that I can deal with it. And oh geez, I'm already 10 minutes behind. And so that can be a real, impediment to compassion. So
Can you speak a little bit about your own tools when you're as a GP? How do you manage? I mean, we were talking a little bit off camera that you were like you practice yoga a little bit. Where did you pick those tools from, and what serves you best now? Do you find, and like, have you got a really positive? It seems like you do, to be honest. But have you got a good kind of like positive relationship between your work and home life, and how do you decharge those
Stresses.
feast of emotions and stresses that you have to deal with?
Yeah. Well, I think that was kind of one of the drivers for me to try and get to the bottom of all of this, was to try and figure out how I could actually nurture that. So for me, I have a meditative practice, taking care of my own physical well-being. I do yoga, I run, and taking care of my own stuff at home with my family.
Yeah.
So work-life balance is very important to me. And, being a GP full-time is very, very stressful to do that work day in, day out. So for me, I found that doing it part-time is better. And so in Canada, I was care of the elderly, which some people would say, oh my God, that's like going from the frying pan into the fire.
Yeah.
But for me, it's somewhat different in that you have, generally your consultations aren't time pressured.
Okay.
So
Yes.
you can go into the nursing home and you can spend more
part.
time.
Yeah, lovely.
So that takes that stress off. And generally the approach is so holistic in geriatrics. It's about really, you have to know the whole person to understand where to go, and it's complicated and it's messy, and that's why some people find it challenging.
Yeah.
But I think that because it's kind of okay to go there, that kind of takes some of the pressure off of me, and just the pace, it's a little bit different.
And
And
also,
the problems
I
are,
imagine it's not all about fixing at
Yeah.
that stage.
Yeah.
It's about like honesty and facing the reality and finding that joyfulness, or like maximizing potential within situations. So that's naturally more compassionate and holistic based, isn't it? Because it's like, well, how can we maximize this experience that you're in right now,
like
rather than like, how can I fix
solution.
this and then get you out the door?
Yeah.
Absolutely. And it was interesting when I was asking, this is one of the questions I was asking the GPs in this other study, and there were sort of three areas where they kind of how they talked about how how compassion evolves or devolves within themselves. And so they talked about motivation. So what was it that motivated them? So part of it was this knowledge that actually I see the benefit. When I am compassionate, I see the benefit.
Cool. Right, that's gratifying.
And so I can be more effective, and patients seem to want it. So
good.
those are motivating. But it's a lot of it also came from their own value systems.
Okay.
So they talked about, this is sort of living by the golden rule. I treat people as you would like to be treated, but actually taking it even to a higher level, which is because obviously how you might like to be treated for one particular illness may not be the way I want to be treated. So it's in the sense of, I want to be treated with compassion, and so I'm going to treat you with compassion. But the details are going to be different. So so the platinum rule really, treat others as they would wish to be treated. But with wisdom. So because sometimes they don't always really know what's best. With all those little caveats. So they talked a lot about how they developed those values, and a lot of them said, this is one of the main reasons why I went into medicine was to help others.
Okay.
Not all physicians go in with that, but I think a lot of them do, and some of them over time lose touch with that.
Okay.
And some of them,
it's quite an
it evolves.
isolated thing, isn't it, for general practice? Because you're not in hospital as well. You're kind of in your own world, and you can kind of like run your practice as you see fit. And
so kind of who do you work with is important. So like a lot of them talked about who they were in their practice with. If they were in a group practice, could they kind of defrag at the end of the day and in a confidential manner say, look, I had this situation and I didn't know, and this happened, and that's, we don't do enough of that. Kind of downloading
and allowing yourselves to appear human to other people who we respect in that sort of professional peer level, which I'd imagine, particularly in the medical community, is probably quite Yeah, quite severe
You know,
to
one
it.
of the things I found was when I was actually doing these interviews, it ended up being quite a significant session for the people who I was interviewing, because they were unloading a lot of stuff that they hadn't unloaded to other people. So I asked them to describe an experience where compassion played a central role in their interaction with the patient, and there were tears, you know, and you know, I remember one of the fellows that I interviewed talking about a young girl that he had, you know, she had come into his practice after his mom had, you know, delivered her, and he'd known her all this time, taking care of her as she'd been growing up, and then in her 20s developed breast cancer, and he cared for her and palliated her, and you know, to have known her through her whole life, and never been able to really properly say goodbye. So you know, you know, I think as physicians we don't always have, you know, the sort of forum to actually process a lot of that stuff. So one of the things that I've been teaching in the medical school is kind of how to reflect, as kind of, you know, there are things coming into medicine like, you know, mindfulness and this kind of thing.
Great.
But I think some of what we need to sort of give them the tools to do is to be able to take those situations and say, okay, wow, I feel really emotionally overwrought right now. This is a point of reflection for me, you know, whether it's something that went wrong, the patient's angry at me, or I'm sad, whatever it is, and be able to have an approach to how to do this kind of reflection.
Like internal journaling, sort of.
Yeah.
Okay, great.
Exactly.
And so if people are listening and maybe they are GPs, they're in the medical profession, or they're just regular listeners who are wanting to know how can they improve their ability to be compassionate both to themselves and to others, are there textbooks that you would say that would be good to read, or are there places that they should reach out to? What are the first steps?
Change the ringtone on your phone to...
I'm yawning you. I mean, I think the first thing is kind of, like doing some reading is fantastic. One of the books that I found amazing was Paul Gilbert's book called The Compassionate Mind.
Okay, cool.
And he's a psychologist who has developed kind of compassion therapy. And so he's spent a lot of time thinking about compassion and what it is. And it has a beautiful kind of model that kind of helps you realize why we struggle a little bit maybe with compassion in our daily lives. So that would be one of my recommendations. I could go on forever about his. It's just like,
does he draw that Aristotle thing as well, that spectrum of compassion indulgence thing?
Well, actually, what he has a fantastic model where he says, look, he looks at our neurochemistry. So looking at it from a very kind of neurochemical kind of way, what happens in our brains, and he says, you know, the compassion neurochemical is oxytocin, which is, you know, the hormone that comes out when
hugging, etc.
Exactly. And then we also have kind of like the fright or flight, you know, adrenaline situation going on, and then we also have the dopamine, which is the reward system. And he says in Western society, really our dopamine is on overdrive. It's like must have, you need more of this, you know, buy, do, you know, you've got to be prettier, you've got to be, you know, you got to be all these things, right? Sort of, you know, we're being assaulted in our dopamine system. And then fear, you know, oh my God, the world's going to hell in the handbasket, Trump's at the head of the, you know, U.S., you know, there's bad news everywhere, and we're already kind of negatively primed, you know, we're primed out of, you know, survival instincts.
It's so interesting that, isn't it?
To notice all the negative,
because that's how we've survived, and that's why the other guys didn't survive.
Exactly.
Because we saw the bad thing first, and we ran away first.
And I love Paul gave a great example at one of his one of the talks I was at of his, where he said, you know, if you go Christmas shopping, you go into 10 shops, and every shop assistant is lovely except for one. What do you go home and talk about? You talk about the one assistant who was horrible to you. You know?
It's horrendous, isn't it?
And so we're already primed that way, and our world around us is also amplifying that, you know, the news and everything. And so and our oxytocin is kind of is probably the least well nourished. You know, we're not spending as much time with each other, one-to-one, in community, you know. And so he says basically, you know, you need all of those three things to be healthy, but we need to be able to kind of tone down those two and boost up our connection.
Yeah. Okay. Yeah.
So I think that's, it's just a very wonderful way of
clear,
thinking about it.
It's kind of
Very
like
clear.
Doshic as well. I'm really curious about where that might cross over with the whole Doshic model thing. I wonder. Anyway, that's curious. Yeah.
And it has so many. I mean, we could talk about it for a long time, but it has so many implications for why birth is going the way that it is, and why there are problems with breastfeeding and all these things, because we just don't have the natural levels of oxytocin. And then we need to get to a point where we need to amp them up in our body naturally in order to open the cervix, or in order to make milk production or bond with the baby, or have that let down reflex that happens. We don't have that natural thing. It's not sitting there at that level. So trying to suddenly gear yourself into it, that's very hard to switch, isn't it?
And there's stress and expectation and all of this kind of stuff that's getting your other neurochemicals all out of whack.
So we need to sit into our oxytocin place.
Right.
We need to sit into
find
our
things that
oxytocin
do
place.
that for us.
So I think there's aside from kind of like, we talked a little bit about kind of your motivation, but it's also your capacity. So to really bring up your capacity, it's about taking care of yourself, as you're saying. So self-compassion, giving yourself the time to smell the roses, exercise, eat well, but also to expose your mind to things that open the doors to compassion, rather than kind of, there is a lot of stuff out there for us to feed ourselves, that feed our minds, that is not healthy. But music, art, all of these things. Burning Man.
Whatever comes your way.
Whatever comes your way.
So stumble upon.
But a lot of the physicians were saying these are the things that make me feel compassionate. If I read a good book, if I have that walk in the park, if I feel like those stores are refilled, and it's there, and it's also, it's like those experiences you have over time of caring as well. Like, they talked about, when my granny was ill and she was living with us, and that experience was so important in my understanding of how to be empathetic. So, taking advantage of those opportunities to kind of learn from them and learn how to be wise, So I think that's the other thing. And then, that's that ability to connect. So how do we connect? And, it's dealing with all that time, learning the skills, those basic skills, like, making direct eye contact, what is your body language, how, and all those kind of more external things. And then understanding relationship and understanding people. I think it's becoming, you really need to become a sort of Sherlock Holmes of human nature. Like because people experience illness and in different ways, and to really look at the person in front of you as an incredible mystery that you are trying to unravel in some way.
That's exciting.
And that's exciting.
Yeah.
What is it? And even that person who comes in yelling and screaming at you.
Yeah.
You're thinking,
There's
instead of going, oh shit, I did something wrong, I'm going to be sued. It's going, wow, what is going on here? Where does that come from? And having that, but again, if we haven't been able to kind of take care of ourselves,
because you have to have the moment to be able to go, ooh, how is that, what's happening in me, and find that exciting enough to be able to explore that and go, when this person's shouting at me, what's my natural response to that? Am I shrinking, or am I coming out fighting? And then having the moment of self-reflection to be able to go, oh, I see this happening. How can I change this in the moment so that I can focus on this?
There's a lot of self-awareness. Like I think you were mentioning that you'd read that one article I'd written, and one of the other sort of things that I read that I found really interesting was this whole, why is compassion important to us as humans? And that there is this evolutionary advantage to being compassionate, and that's based on the fact that we're social creatures, right? And so if I'm good to you, you're more likely to be good to me. So there's mutual benefit.
It's a network for survival. Yeah.
But aside from just, if I'm good to you, you're going to be good to me, there's also, actually, when I'm good to you, I feel better. You know? But in this one particular article that I was referring to in that piece of writing, she talks about there are these sort of emotional decisions that we make along the way when we're interacting with somebody. So, you know, are you relevant to me? That's the first one, you know.
Okay.
Are you part of my tribe? So if you're part of my tribe, you're more likely to be relevant. So it's easier, obviously, to be compassionate to your child, to your, you know, your friend, rather than to a stranger or someone who is very different or very unusual, you know. So it takes, you know, an additional sort of thought of, you know, you're human. You're human, and so therefore you are part of my tribe. You know. And then, and if we're not able to do that, then we might be going, I'm glad you fell down and hurt yourself. You know, if you're not part of my tribe, then, you know, maybe you're a threat. So maybe it's good that that bad thing has happened to you.
Lessons for Donald Trump.
Yes, exactly.
You should just retitle the podcast.
And then the next one is, you know, are you, am I able to cope with what you're going to, with your suffering? You know, so it's kind of like, ooh, okay, where am I at? Okay, if I can't cope with you, then I'm going to be afraid. I'm going to be like my, you know, adrenaline's going to be up, fear factor, you know, I can't cope with this, you know, so, you know, I want to run away from the situation.
And it's infectious as well, isn't it?
Yeah, absolutely. And then the fact of deserving. So we do this kind of analysis. You know, do you really deserve my compassion? So that's
mean.
It is mean.
But it's so true.
But it is mean, because you know you're investing in that person, and if they're not, so you know, in kind of a non-medical kind of way, you know, if you're part of my tribe, it's worthwhile for me to be compassionate to you. If I think you're probably going to be compassionate to me, so you know, I'm going to take care of my kid because when I'm old, they're going to take care of me. And so if I've seen something in your behavior or whatever that makes me think, I don't know whether you're deserving of my compassion, then I might feel angry if you seem to be wanting something from me.
Okay, that's really
and
interesting.
so you know what all those kind of different feelings, if we kind of notice that they're coming up, it's not unnatural to feel them. But to kind of say, oh, I'm feeling fearful. I must be feeling tired, and this is why I'm not able to, or this person, you know, I've given them this medication and we've discussed it, and yet they're still not taking it, and like, you know, geez, you know,
Must
I
have met
think
them in a past life.
why are they doing this? Or you know, I'm only trying to help them, and they're not. You know, instead of kind of thinking about, okay, well, there must be a reason. So, so I thought that was really kind of interesting. You know, and I think that that's the kind of work that if you really kind of can keep, you know, compassion as your focus, those are the kind of things that are going to come up.
Cool. Great. Lovely. Okay, so we had one. We were starting just doing your like research references. So was Paul? What was his book?
Paul Gilbert.
Paul Gilbert.
The Compassionate Mind.
Great. Any others? Any other quickies? That's a big one, to be honest.
That is a big one. I mean, if for the medical things, this Medicine and Compassion was brilliant.
Okay. Great.
I think the Paul Gilbert one is my favorite one. I mean, there's just so much written, you know, in Buddhist literature, obviously, that and in other. There's a lovely, what's her, Karen Armstrong? Do you know her?
No, I don't know.
She is sort of a theological writer, and she has She has a book called Living a Compassionate Life or something like that, and she, you know, takes examples from lots of different religions, spiritual traditions, and just finds the common theme.
Oh, nice.
And she just talks a little bit about how we can all bring more compassion into our lives. And she had a fantastic project, which I can't remember exactly what the name of it is. But if you look at Karen Armstrong, because I think that's a really beautifully articulated book about compassion and how you can easily bring it into your life.
Kind of universal themes of it. Oh, nice. Okay.
Yeah.
Cool. So if people want to find, it was so nice. If people want to find you and like as a GP or otherwise, what's the best way for people? Do you have any kind of, are you a presence online in social media or in other ways?
I do have a Twitter account.
Great.
We'll
stick that into the show notes.
Deadly. I haven't been tweeting a lot in the last little while, but you will see some of my stuff coming up there.
Is it
so,
Jane
yeah.
Uygur?
Yeah.
It is? Great.
Yeah.
Did I get that okay?
Yeah.
We'll be compassionate to you. Very
Yeah, you're being very forgiving. That's for sure. Brilliant. Okay,
Jane,
cool.
we could have talked to you for ages.
Really could.
And
yeah.
hopefully we'll be able to talk to you again sometime.
Oh, it would be an absolute
treat.
pleasure. Absolute pleasure.
Thank you.
Dodie, thank you
you.
very much. Cheers.
Thanks.
And for you guys, obviously every podcast we do, we like you to come along and post comments, whatever, and those ones that we like, we'll be doing another series of giveaways fairly soon of our lovely News S duffel bags, full of loads of goodies from the Hop Sack and from News S themselves. And so in the meantime, stay tuned, enjoy, like, subscribe. We're now on Spotify, so you've got Spotify, iTunes, YouTube,
There's
wherever.
no excuse not to listen to all our podcasts.
There you go, yeah.
So exciting.
Dodie, okay, thanks for watching. Cheers.
Thank you guys,
Thanks
bye.
again, Jane. Cheers.
My pleasure.